Hey everybody, how's it going? My name's Derek, I'm a respiratory therapist, and today's lecture is called ACLS Deep Dive, What is PEA? Now, this lecture is inspired by a question I got from a student recently, and she asked me essentially that, what is PEA? Is it just sinus rhythms, or can it be other things too? And I think that there can be a little confusion around that, so that's what we're going to talk about today. We're going to talk about what really PEA is, along with a little bit about what can cause PEA and some cardiac physiology and hemodynamics as well. So without further ado, we're going to get into the objectives here. So first objective, describe cardiac rhythms in cardiac arrest. Then we are going to identify a basic definition of PEA and what it really means. Then we are going to review reversible causes, which are your H's and T's, basically what can cause these rhythms. We're going to describe some hemodynamic parameters, just in basic levels, and that kind of helps you get an idea of what's going on with these H's and T's. We are going to recall physiology behind cardiac rhythms in relation to H's and T's, meaning that we're going to kind of put those two things together. Then down here, we're going to articulate the difference between pseudo-PEA and true PEA. This is the point in the video where we're going to give you kind of a more accurate, more precise, but slightly more complex definition of PEA. But we're saving that for more towards the end of the video because I don't want to get too complex too early on. I want to kind of warm you up first and talk about hemodynamics and stuff before we really get into the nitty-gritty of things, so that's why we save that towards the end. And then finally, we're going to summarize the primary causes of cardiac arrest. So without further ado, let's get into it. Okay, so rhythms in cardiac arrest. ACLS categorizes it into two different kinds of rhythms. We have your shockable rhythms, your VTach and VFib, and your non-shockable, which is PEA and asystole. VTach and VFib have additional steps and interventions in the cardiac arrest algorithm, as you will recall. We can defibrillate, and we can also give antiarrhythmic medications, typically either amiodarone or lidocaine, according to the algorithms. PEA and asystole, they just get the compressions and the epi. That's it, besides treating reversible causes. So what does PEA really mean? Well, the basic definition, it's pulseless electrical activity. It's just as it sounds, electrical activity of the heart without any palpable pulse or cardiac output. This can be any rhythm besides VTach and VFib that is present on the monitor but presents as cardiac arrest in the patient. It could be sinus rhythms, atrial rhythms like AFib, A-flutter, junctional rhythms, blocks, agonal, really anything you see that's not VTach, VFib, or asystole is PEA, according to this definition. Now, kind of going off this sort of more basic definition, technically speaking, VTach and VFib, let's think about this. They are electrical activity of the heart, right? As in, it's not asystole. And VFib all the time, and VTach a lot of the times, are non-perfusing rhythms, meaning the patient is pulseless. So kind of going by this basic definition, VTach and VFib are kind of technically PEA. They're pulseless electrical activity, right? Now, once again, a more precise definition of PEA will be discussed later, but just think about this for a second. Okay, so then why are ventricular rhythms so special? If they are kind of just PEA, why do we treat them differently? When it comes to VTach and VFib, we are assuming that the reason the patient is in cardiac arrest is most likely due to said lethal arrhythmia. With VFib, there is no organized contraction of the myocardium at all, and with VTach, a lot of times there is not enough, really, there's not adequate contractility for there to be any kind of cardiac output, right? This is why the patient is in arrest. These lethal rhythms can be converted either electrically or chemically, so that's why our goal with VTach and VFib shifts to converting these rhythms, because we're assuming that will probably give us ROSC. When it comes to any other rhythm present during arrest, the same cannot be said. The reason why your patient is in cardiac arrest is not due to the sinus tach or whatever rhythm you see on the monitor. That should be a perfusing rhythm, right? You cannot fix the rhythm. Electrical and chemical conversion are not going to be helpful in that case. Something else is causing this arrest. There's some other underlying cause. Okay, so now that we've given kind of a basic definition of PEA, let's talk about why is my patient in PEA, VTAC, or VFib? Well, that's your H's and T's, your reversible causes. We've got hypovolemia, hyper and hypokalemia, hydrogen ions, which just means acidosis, hypothermia, hypoxia. We've got your thrombus pulmonary, which is a PE, thrombus coronary, MI, tamponade cardiac, tension pneumothorax, and toxins. And we're going to talk about each one of these with a decent amount of detail. And by the way, here, this link at the bottom, don't worry, this and all of my other references are going to be included in the description of this video, so you can read through everything yourself. But this is a good resource for in-depth guidelines on not just H's and T's, but many other cases of cardiac arrest as well. Okay, so before we get into the reversible causes, we're going to do a quick hemodynamics refresher. To really understand the H's and T's and what's going on, why they're causing people to go into cardiac arrest, you have to understand at least a little bit about hemodynamics and cardiovascular physiology. That's going to be kind of the focus here is sort of what's going on with the heart in each one of these things. So first of all, let's remember this equation from school. Cardiac output equals heart rate times stroke volume. So essentially your cardiac output is how many times per minute the heart is beating and how much blood is being pumped with each beat. Now your stroke volume is affected by three things: your preload, your afterload, and contractility. Preload is how much the ventricles are filling with blood. The afterload is the resistance or the force that the heart has to pump against in order to expel that blood into the system. And contractility is the ability of the heart to contract. Several of the H's and T's relate to a problem with one of these three things. And then also another important equation to think about is this one down here. Mean arterial pressure equals cardiac output times systemic vascular resistance. Now that's important to remember because in order to have a blood pressure, it's not good enough to have a properly beating heart with good cardiac output. You also have to have some kind of vasal tone going on. You have to have some kind of vascular resistance to perfuse organs. So the first reversible cause that we're going to talk about is hypovolemia. This one typically presents as PEA. Now, at the start of each one of these things, I'm going to say kind of what rhythm tends to present on the monitor, but don't take this as gospel. Any of these reversible causes of cardiac arrest can present in any rhythm or asystole. I just want you to think physiologically, what are you kind of more likely to see with this? So that's all that's for. And once again, hypovolemia, typically presenting as PEA. Now, this is a preload problem. The heart is unable to fill correctly. There is a critical lack of intravascular volume. Now, think about it. If there's not enough blood for the heart to fill, there's nothing to pump out, right? And building off of that, depending on the situation, such as trauma or hemorrhagic shock, dehydration, this might not actually be a true PEA. See, the thing is, the patient might technically have some kind of cardiac activity and some kind of cardiac output, but because there's so little intravascular volume, it's very, very little, and there's not enough perfusion to the point where there is no pulse, and it's not enough to be life-sustaining, whatever cardiac output there is, right? It's not enough. And this is sometimes referred to as pseudo-PEA. I want you, don't think too deeply about this, but I want you to kind of take that and just put it somewhere in the back of your mind. Just put it on the back burner and leave it there, because that's going to come up later when we talk about our more precise definition of PEA later. So with hypovolemia, this is typically not an immediate cardiac arrest. The patient tends to kind of degrade until pulses are lost, right? This isn't something that's just like a sudden onset, right? Unless it's truly massive bleeding, but most of the time it's kind of a slow process, well, relatively slow. And the way you fix this is give more fluids, especially blood if it's a hemorrhage, because crystalloids cannot carry oxygen. Patients may need surgery and bleeding control if some kind of trauma or hemorrhage is present. And also another thing to think about is that if you have a trauma case and you think they're hypovolemic and there's like multiple injuries, there could be multiple causes of cardiac arrest. You might have some of the other things we're going to talk about later, like a tension pneumothorax or cardiac tamponade as well. So just keep that in mind. And a final note here, chest compressions and epinephrine are not helpful in hypovolemic arrest, especially when it's traumatic. Now, with epinephrine, what happens is when your patient is in hypovolemic shock or something like that, their body is going to release endogenous catecholamines, epinephrine, norepinephrine, those kind of things internally to try to preserve cardiac output. So slamming more epi into their veins is really not going to do a whole lot for them, right? They're already kind of depleted their endogenous catecholamines. And chest compressions, once again, this is not a contractility problem. This is a preload problem. This is a volume problem. And doing chest compressions is not really going to help the heart fill, if you think about it, right? Okay, here's our next one, hypokalemia. So these electrolyte disturbances can cause VTAC, VFib, asystole, and other arrhythmias. This one is a contractility problem. Remember what I was talking about earlier with VTAC and VFib? It's a problem where the heart is not contracting properly or at all. Now, what's the mechanism behind this? Potassium is vital to operating the sodium-potassium pumps that are responsible for maintaining myocardial action potential. Without a proper potassium gradient, myocardial excitability will increase with hyperkalemia and decrease with hypokalemia, leading to early or late repolarization, and the velocity of cardiac conduction will increase or decrease, and as a result, new arrhythmias become likely. Basically, the cardiac membrane just gets destabilized, and the patient has a high chance of going into some sort of arrhythmia that's probably lethal. There are many different things that can cause this, but a few of them are renal dysfunction, metabolic acidosis, or in the case of hypokalemia, metabolic alkalosis, and some drugs as well. With hypokalemia, you have to give potassium slowly. Please never give your patient a push of IV potassium. A push is lethal because then you're just going to put them in hyperkalemia and they're going to go into VFib. And with hyperkalemia, you can give IV calcium gluconate or carbonate, I believe, which will stabilize the cardiac membrane and basically kind of stop your VFib problem, but it won't actually fix your hyperkalemia problem. For that, you're going to need one of two things. IV insulin with glucose, if they're euglycemic, will cause an intracellular shift of potassium to reduce the blood serum levels, and also beta adrenergics such as albuterol given can also shift potassium back into the cells. Now, in the case of refractory hyperkalemia, hemodialysis can be used to physically remove potassium from the body. Acidosis. So with this, we're typically talking about metabolic acidosis. As a personal aside, I have seen some patients with a pH that's very, very low with hypercapnic respiratory failure, but a lot of the times if we're talking about a life-threatening acidosis, it's usually metabolic. Now, this can be caused by either a loss of bicarbonate or an accumulation of extra acid. This can be a ketoacidosis, such as DKA, with the buildup of ketone bodies, lactic acidosis, such as you see in sepsis, renal failure, toxin ingestion, diarrhea, rapid administration of fluids containing chloride, and many other things. So what's the mechanism here? This results in hypotension, Peripheral vasodilation drops vascular resistance, and acidosis also decreases cardiac output. It also causes cardiac arrhythmias, hyperkalemia, which is going to cause more cardiac arrhythmias, as we already talked about, decreased effectiveness of catecholamines, so your pressors aren't going to work very well, and reduced oxygen delivery to the tissues. Your oxyhemoglobin curve shifts to the right, so you're getting a lower saturation of oxygen for a given partial pressure of oxygen, and the total oxygen content is a lot lower. Now, when it comes to metabolic acidosis, it's very tempting and very common to just administer some sodium bicarb thinking that that's just going to fix the problem, right? Oh, they're acidic, well, let's just give them a base, right? But studies have shown that it doesn't improve outcomes except in some specific scenarios. But in general, if your patient is in cardiac arrest and their pH is low, giving bicarb is generally not helpful. It's best to attempt to reverse the underlying cause of the acidosis. For example, this might not be necessarily a respiratory acidosis, but it might be a mixed acidosis. Maybe you do have some hypercapnia and you also have a metabolic problem. Well, maybe we can at least blow off some of that CO2 and help correct the pH a little bit, right? Those kind of things. Now we have hypothermia. This can present with any rhythm, and this tends to be seen with environmental exposure, drowning, or secondary to some other problem or drug. In healthy adults, hypothermia-induced cardiac arrest can occur when the core body temperature drops under 30 degrees Celsius, and in the elderly, it can occur at slightly higher temperatures, just under 32 degrees Celsius. Now, what's the mechanism here? There's a couple mechanisms, actually. Hypothermia increases myocardial irritability, making lethal arrhythmias likely, kind of like hyper and hypokalemia. The other thing here is that hypothermia also causes bradycardia in response to a global decrease in metabolism. Basically, as the body gets cold, everything slows down, including the heart. How do you fix this? Well, the patient needs time. They need time to rewarm, and you just have to buy them time. This is the patient that you are going to do an extended code on. You are going to perform CPR for a prolonged period of time while active rewarming is done. Methods should include things like heating pads, warm IV fluids, internal lavage of different body cavities, CRRT, hemodialysis, and even ECMO. Now, the thing is here is that outcomes are actually better with hypothermic arrest patients than those with normothermic cardiac arrest, which is kind of interesting, but if you think about it, we tend to do targeted temperature management for some of our cardiac arrest victims to try to help improve their outcomes. So it's like if they're already cold, it kind of makes sense that it actually helps outcomes a little bit. And a little note down here at the bottom for ACLS. If core temperature is less than 30 degrees Celsius and VFib persists after 3 shocks, you should delay further defibrillation until core temperature is above 30 degrees Celsius. Also, you should lengthen the epi interval. You're going to double it to every 6 to 10 minutes if core temperature is less than 30 degrees Celsius. And our next one is hypoxia. As an RT, this is kind of the one that I'm most familiar with. Hypoxic cardiac arrest can present with any rhythm. This is seen with respiratory failure and arrest, asphyxiation, carbon monoxide poisoning, methemoglobinemia, airway compromise, and some other things as well. Our body needs oxygen to survive, simple enough. Oxygen is the final electron acceptor in the electron transport chain in cellular respiration. You remember that one from biology back in the day? So without oxygen, aerobic metabolism is impossible and cells will eventually die because they can't metabolize ATP. Anaerobic metabolism is possible for short periods of time, but leads to a buildup of lactic acid and is not sustainable. The end result of this is multi-system organ failure and death. Now, cardiac-wise specifically, it will cause arrhythmias, bradycardia, and tissue death, which can lead to cardiac arrest. The solution for this one I hate to say it, but it's fairly simple. You give oxygen, you establish an airway, and you treat other underlying causes if present, right? If they drowned, you might want to think about rewarming, those kind of things. And now we're on to the T's. Our first one is pulmonary embolism. So PEA is the common rhythm here, but other rhythms are possible. This is often caused by a DVT, but there are other causes too. Now, PE is both a preload and an afterload problem. I want you to try to imagine this. So, especially with a massive pulmonary embolism, you have the right ventricle that is trying to pump blood into the pulmonary arteries, and you have a massive blockage that is stopping blood flow. That is a physical obstruction. That's what's going on here. The blocked pulmonary artery causes right ventricular strain because that right ventricle is trying to pump against that. You get increased right ventricular afterload, obviously, and reduction of left ventricular preload because there is less pulmonary venous return, right? Less blood is able to make it through that blocked pulmonary artery, and therefore you have less blood draining through the pulmonary veins to the left ventricle. The end result here, you end up getting this right ventricular dilation, which can then shift the interventricular septum between the left and right ventricle. It can shift it leftwards and compress the left ventricle, making things even worse. This is a form of obstructive shock that can degrade to PEA. The strain on the right ventricle can also cause right ventricular ischemia and infarction as well. Definitive treatment involves removal of the embolus via either thrombolytic therapy or actual mechanical embolectomy. Mechanical circulatory support such as VA ECMO can help buy time. And here's our next one, myocardial infarction. VTAC and VFib tend to be the more common rhythms with this. This is caused by an obstruction of a coronary artery that leads to ischemia and infarction of myocardial tissue. What's the mechanism? Well, cell death and ischemia can cause changes in myocardial automaticity, which can lead to the generation of arrhythmias such as VTAC and VFib. Basically, this dead tissue is affecting the conduction and changing the way that the heart is regulating its beat. The MI can also reduce myocardial pump function. Think about it. Dead tissue is not going to contract properly. This is a contractility problem in that case, and that can lead to acute heart failure and result in cardiogenic shock that can also degrade to cardiac arrest. Basically, with that, the heart just can't pump anymore. There's a pump failure in that case. What's the solution? Well, PCI or thrombolytic therapy restores coronary perfusion. Ventricular arrhythmias obviously should be defibrillated and treated appropriately, but if your patient has cardiogenic shock physiology, something like an intra-aortic balloon pump, a left ventricular assist device, or VA ECMO can all support cardiac output. This is the patient where you might see them in the CV ICU on ECPella or something like that. Next up, we have cardiac tamponade. This one also tends to present as PEA. Other rhythms are possible. And tamponade is a hemodynamic/clinical diagnosis, not an anatomical one. This is caused by a pericardial effusion of any size, potentially. The effusion itself can be due to a number of things: trauma, infection, autoimmune or inflammatory problems, and neoplasms. This one, kind of like the PE earlier, is also a preload problem. What's the mechanism? Well, a buildup of pericardial fluid increases pressure in the pericardium, which compresses the heart and decreases venous return to the heart, therefore decreasing ventricular filling and decreasing cardiac output. You have the pericardial sac around the heart, right? And there's normally a certain amount of fluid, but if that continues to grow and grow, that pericardial sac can't stretch. And so what's going to happen is it's going to increase pressure on the heart more and more, and you're just squeezing the heart. And that is really, really bad. Kind of like the pulmonary embolism, this is also an obstructive shock that can cause cardiac arrest. The treatment here is pericardiocentesis. Volume resuscitation and pressors can buy you time, but they won't resolve the tamponade. Next, we have tension pneumothorax. With this one, PEA is also common and other rhythms are possible. This can be due to either a traumatic, iatrogenic, or spontaneous pneumothorax. Pneumothorax, much like both the PE and tamponade, is also an obstructive shock and a preload problem. This is a pneumothorax where a one-way valve allows air to enter the pleural space but not leave it. As a result, intrathoracic pressure rises and venous return is impaired due to compression of the heart and vena cava. As I said before, this is another form of obstructive shock. The lung is also compressed, which reduces oxygenation and ventilation as well. So think about this one. We were just talking about the tamponade with that pericardial sac that is compressing the heart. In this case, what's happening is the intrathoracic pressure and compression of the mediastinum is what's compressing the heart. But the end result is basically the same. It's just a mechanism that's a little different, but end result's the same. So the way we solve this is a needle decompression. That will relieve the tension physiology, but won't actually fix the pneumothorax. In order to do that, you have to place a chest tube, and that will actually relieve the pneumo itself. But the needle decompression is what's going to stop your patient from coding. And now we saved the most complex reversible cause for last, which is toxins. There are a wide variety of etiologies and presentations. This could be accidental or purposeful overdose. There are many potential causative agents. A few are opioids, beta blockers, calcium channel blockers, benzodiazepines, cyanide, carbon monoxide, digoxin, organophosphates, etc., etc., etc. This list is far from comprehensive. There are a ton of different causative agents. Most of these substances, they cause some other kind of problem, which leads to cardiac arrest, right? You might get arrhythmias, respiratory depression, hypoxia, something like that. Acidosis. Treatment is highly specific to what the agent is, right? You don't know the antidote if you don't know what they're poisoned with. Knowing what poison is causing the arrest will allow for definitive treatment, but supportive measures take priority. You have to treat the patient in front of you, and it is not always feasible to identify the causative agent. Extracorporeal therapies for drug removal, like dialysis, and cardiac support, like VA ECMO, might be necessary to buy your patient enough time to metabolize the toxins out of their system. Some specific antidotes here at the bottom of the page. We have naloxone for opioids, we have flumazenil for benzodiazepines, and we have atropine for actually quite a few different things. Beta blockers, calcium channel blockers, digoxin, organophosphates, local anesthetics, carbamates, and those, once again, just a few of many different agents. A toxin-induced cardiac arrest is fairly rare, but there's so many different things that can cause it. You have to kind of rely on what's this patient's history of present illness, right? What's going on in order to really figure out what they were poisoned with. And finally, as I promised earlier, we are going to talk about a more precise definition of PEA. What is true PEA? Well, true PEA can only be diagnosed with point-of-care ultrasound, arterial line tracing, plethysmograph, and end-tidal CO2 waveforms. Really, the point-of-care ultrasound is the most important thing, but the other things can kind of help give you a picture too. And here's the definition. You have no pulse, you have an organized rhythm on the monitor, and cardiac standstill. The heart has stopped beating completely. This is oftentimes referred to as PRES, I'm just going to call it PRES, pulseless with a rhythm and echocardiographic standstill. There is a complete disconnection between electrical activity and mechanical activity. right? You're seeing electrical activity and you have no mechanical activity. The patient might as well be in asystole. Meanwhile, pseudo-PEA, the definition here, think back to hypovolemia like we were talking about earlier. No pulse, organized rhythm on the monitor, and when you go to do your point-of-care ultrasound, you see cardiac activity. This is referred to as PREM, pulseless with a rhythm and echocardiographic motion. In this state, the heart is still contracting to some extent. It's just that the heart's contractions are probably not adequate enough to perfuse the patient's organs, right? It's not life-sustaining. But signs of cardiac movement is a big deal because it means not only the patient's odds of survival are much higher because the heart is still beating, we don't really have to restart the heart, but the other thing too is that technically the patient isn't in cardiac arrest. They are in a profound shock state. The earlier AHA definition of PEA that I gave to you guys does not distinguish between these two types. It treats everything that looks like PEA the same. It doesn't say anything about using point-of-care ultrasound or anything like that. But the truth is that identification of true PEA versus pseudo-PEA will likely change your approach to management of that patient, right? If you identify pseudo-PEA, you're now going to treat them as being in a state of profound shock versus being in true cardiac arrest. But I will say, at the end of the day, no matter which pathophysiologic state your patient is in, the identification of treatment of the underlying cause should be prioritized. That pseudo-PEA will quickly deteriorate to a real PEA or asystole if you don't fix the problem. Now, if you do that point-of-care ultrasound and you see that they're actually in pseudo-PEA, that might kind of help you dig a little deeper into, okay, why is this happening? And here's a quick little activity. One of the reasons why I left this slide to the end is because now that we've had some time to talk about not only what causes these cardiac rhythms, what causes cardiac arrest, but also since we talked a little bit about hemodynamics as well, and preload and afterload versus contractility problems, I want you to think about this. Which of the previously discussed reversible causes are more likely to present as pseudo-PEA versus true PEA? And I'll give you a second to think about it. So here's my thought process, and I'm not saying this is, gospel or whatever, but here's just how I think of it. Obviously, hypovolemia, we kind of already talked about that one, but also the other reversible causes that present as possible shock states. The ones specifically that are obstructive shock, your pulmonary embolism, your tension pneumothorax, your cardiac tamponade. All of those things, if you think about it, those are problems with preload and or afterload. There isn't a problem with the heart contracting. If you catch it, especially early enough, the heart might still be beating. It's just that they have so much of a preload or afterload problem that they're just really not getting much of any cardiac output, right? And another one too that might be possible, the MI, if it presents with cardiogenic shock. That's another one where you might possibly see a pseudo-PEA. And once again, that's not, based off of any research studies or anything. That's just going purely off of physiologically what's going on. And here's another final tidbit I want to leave you with. Based on this new definition of PEA, if you think about it, when earlier I was saying VTAC and VFib, well, they're kind of just PEA. Well, based off of this definition, if you think about it, VTAC and VFib are kind of just pseudo-PEA, right? There is a rhythm and there is myocardial activity. I don't know if you've ever seen an ultrasound of somebody who is in VFib, but you can see the heart fibrillating. It is moving. It's just not contracting properly, right? There is myocardial activity, but it's not enough to produce perfusion. And that way, it kind of is a pseudo-PEA, isn't it? I think one of the important lessons that this really teaches me, at least when I was doing my research, is that point-of-care ultrasound during cardiac arrest can be very, very useful as a tool. And I don't know where you guys are at in the United States or in the rest of the world, whether you guys are using point-of-care ultrasound in your cardiac arrest victims. Me personally, I've only seen it a few times, mostly in trauma cases. Besides that, it's kind of not common where I am, but I really think it should be more common because something like this, identifying true PEA versus pseudo PEA, and also using that ultrasound to identify reversible causes, can be a game changer potentially. Okay, everyone, that's going to do it for today's video. Thank you so much for sticking with me through to the end. If you have any comments, questions, or concerns, please feel free to leave them in the comments, and also let me know, what should I talk about next? What else do you guys want to hear about? I hope you all have a great day, and I will see you all next time.